Hello, everyone. The title of my presentation, Antiepileptics, Drugs, What to Choose and When to Stop. Okay. So that's the outline of my talk. I'll have a brief introduction. Then we'll have an approach to choose anti-seizure medication. Then that approach, I'll apply it to 6 cases. Then we'll answer the question of when to stop. Then we'll summarize and end the presentation. You can see this is a very busy slide, but the point of it is you could see the number of anti-seizure medication here. The next slide maybe put some timelines on it. We have plenty of them. So which one of these are we going to use? So you need to keep these questions in mind. I have what I call the holistic approach, like looking into this from more than one angle. I believe if you keep these questions that are written here in mind, you probably won't go wrong in choosing the appropriate anti-seizure medication. To start with, that's very important. You need to decide about the type of epilepsy and seizure. Is this a generalized seizure or generalized epilepsy or focal or both? Because each one of them may have a different treatment plan or a different anti-seizure medication to be chosen. And then the second question I put here related to the first question. Do I need a broad spectrum anti-seizure medication or a narrow spectrum is good enough? The difference between broad spectrum and narrow spectrum is the broad spectrum anti-seizure medication, they work basically for both focal and generalized. Most of the narrow spectrum anti-seizure medication, they only work for focal seizure with one exception that I'll mention later. And then this third question I put here, what are the comorbid conditions? This is very important to keep in mind, and you'll see that in the illustrated cases that I have for you. And then again, another important question, is this a woman of a childbearing age? This is a very important question. Always keep that in mind. And then what are the side effect profile? What is the mechanism of action? This especially applies if you are going to combine treatment. So it's a very important question. And again, what's the clearance of the drug? The clearance of the drug is very important when you are considering the comorbid condition, someone with hepatic problem, with renal problem. You need to know how the drug is metabolized and how is it cleared. And then is there any drug-drug interaction? Like if you are putting this anti-seizure medication, are you going to have major drug interaction causing problem to the patients? Maybe an example of that, carbamazepine and some of the antibiotic, the microlides, erythromycin, and so on. And then do I need to combine anti-seizure medication? And then cost is also important, but it may not apply a lot here, especially in our health system in Kuwait. Now, as I said earlier, you need to decide, is this focal, generalized, unknown? This is based on the latest classification of seizures. This is the same, but it's a little bit expanded here. We could see, like for the generalized, they have the kind of subcategory, myoclonic, tonic-clonic. Similarly here for the focal onset and unknown onset. Next is putting all these together, you know, the classification of epilepsy rather than just the seizures. So it's the seizure types, then the epilepsy type, keeping the etiology in mind is also very important. Sometimes you need to direct your treatment to the etiology. For example, if you had an autoimmune condition, you probably need an immune modulating agent and all that. Here, I put a table. This is not inclusive of all the medication, but you could see here are some broad spectrum anti-seizure medication. As I told you, these work for both focal as well as generalized seizure. I think levetiracetam here, brivaracetam although there are not kind of large-scale studies in generalized epilepsy, but I believe it works. That's why I did not put it here under the broad spectrum. But I believe it does work. It has similar mechanism of action. So brivaracetam is not included here. Among the medication, like what to choose, lefenamide is an effective drug, but we don't use it as a first-line agent. The reason being the rare side effect of aplastic anemia and fulminant liver failure. These are very dangerous complications. So when I was saying earlier, like, you need to keep in mind the side effect profile before you use the medication, this applies to this particular medication that we don't use very commonly. Similarly, vigabatrin, it can lead to blindness, but it's used in children who have infantile spasms. I was saying these medication work for focal epilepsy, narrow spectrum, with one exception. The exception is rivaroxaban is used for generalized absence, but it's very narrow spectrum. It doesn't work for the GTC. It doesn't work for anything else but the absence. So you need to think of these medication. What kind of medication do I need to use? Am I dealing with a focal epilepsy, generalized epilepsy, and then and which one of these kind of category you need to choose? I think it will be easier when I explain to you with the cases. This is a very busy slide, but you could see if you have comorbid condition, the purpose of this slide, like your choice of medication and the medication to avoid, kind of will change based on the comorbid condition. For example, if you have someone with hepatic problem here, you won't use valproate or lamotrigine. So on someone who has lung disease, you would not use the benzos. And this goes on and on. You could see here the medication here to be avoided. Most of these medications, if not all these medications are very strong enzymes inducers. For this reason, they have a strong drug-drug interactions, and they get avoided, for example, here in hypothyroidism, osteoporosis, and so on. So again, the point of this busy slide was to keep the comorbid condition in your mind and kind of choose the best drug that works for these patients. Now, when we ask the question, is this a woman of childbearing age? I got this slide from the North American Anti-Epileptic Drug Pregnancy Registry. You could see here lamotrigine and levetiracetam, large number of patients, and the risk of malformation, if you see here, like 1.9, 1.8 for both of these medications, and when you come to the internal control, is like 0.9. The external control is similar kind of to the general population, like 1.7. So these are really the drug of choice for a woman with childbearing age. And again, from this slide, you need to avoid valproate. You really need to avoid valproate. Lacosamide is new. There isn't a lot of patients that have been on it, but, and again, you could see the confidence interval is large here, but it's something to kind of watch for. And then the rest of the medication, as you could see, phenobarb is maybe a little bit kind of similar to valproate. So from this slide, lamotrigine and levetiracetam are the best. Now let's start with these cases. Let me play the video. So I play any one of these videos, I want you to decide what kind of seizure is this, and distinct one seizure medication we are going to use here.
Fresh linens, ask your nurse. Another thing you can count on, assuming your condition and treatment allow, are 3 square meals a day. Breakfast is served from 7:30 to 9 in the morning. Lunch is 11:30 to 1.
I'm going to give you a code word. I want you to remember bridge for me. Can you point up to the ceiling? Can you tell me where we are?
Meal was served.
What's the name of this place? Okay, you're all right.
Oh my God, please help me, God. Please help me, God.
Show me 2
I love
fingers.
you and trust you, Jesus. Please help me.
Okay, show me 2 fingers.
Oh my God, help me, God.
Where
Please
are
help me.
we? It's
Oh my God,
okay.
help me. Where I work at, God. Please take us away from me, Jesus. Please. Oh my God, take it away from me, God. Please. Oh my God.
Tell me your name. What's your name? Good, good. Where? You're okay. What month is it? What month is it? What month is it?
Oh my God, help me. Take it away, Jesus. Please.
You're okay, Bill. You're okay.
Oh, son. Oh my God, help me.
What's 2 plus 2?
4.
Good. What time is it on that clock?
10 after 1
AM or PM?
p.m.
Great. Great. Spell hands for me.
H-A-N-D-S.
Good. With your left hand, touch your right ear. Awesome. Good job.
The housekeeping staff will come in between the hours of 8
Okay,
a.m.
so
If you were out of
so with this is a clearly focal seizure. So do we need a broad spectrum anti-seizure medication? The answer is no. So, but keep the comorbid conditions here in mind. This man has ischemic heart disease. He has dyslipidemia, diabetes. Are we going to use something like carbamazepine? It works. I mean, most of the comparative studies that are done against carbamazepine because it's a very effective drug. But I don't think it's a good choice here. Reason being, it's a very strong enzyme inducer. It will mess up his dyslipidemia. And even if he has medication for his ischemic heart disease, if he has beta blocker, calcium channel blocker, he will probably reduce the effect of these medications. So I don't think this medication, although it's an effective medication, I don't think it might be my #1 choice here. So we would want to choose a medication that does not kind of have this drug-drug interaction and reduce the efficacy of the other medication that the patient is using. I think levetiracetam is a reasonable choice here. I know it's a broad spectrum anti-seizure medication, but I think it's a very appropriate one to use here. And we know when I was talking about the side effect profile, in the adult population, maybe up to 30% of some people kind of get anxious or depression or get angry. So if we face this problem, I think oxcarbazepine or L-carbazepine could be kind of a substitution, a good substitution. Although they may also induce the liver enzyme, but not as bad as carbamazepine. Also, glucosamide might be an appropriate choice here. Again, looking to the side effect profile, some of the doctor might be afraid of the bradyarrhythmias that it might cause, but not all ischemic heart disease patient will end up having bradyarrhythmias from the use of glucosamide. So to summarize with this case, you'd want to avoid a medication that has a strong enzyme-inducing, liver enzyme-inducing features, the like of carbamazepine, phenytoin, and so on. And then one of the, I think the best choices here will be levetiracetam, glucosamide, and trileptal or oxcarbazepine. And one of these will work. Let's see the second case here.
Help! Help! Whoa, girl! Okay, I want you to remember the word dynamite. Watch out for your glasses there. Show me 3 fingers. Okay. Clap your hands 2 times. How old are you? How old are you? Show me 4 fingers. Can you do that? That's it. How do you say your last name? What's your last name? Hi. Okay. Can you count to 10 for me? Count to 10. You're drooling a little bit. You look a little grayish, but you're doing okay. Can you clap your hands 2 times? What is this on my nose? Code word is dynamite. You're doing good, Miss Abrams. Thank you. You're okay, hon. Relax.
Okay, so as you could see, this is also a focal seizure. So do we need a broad spectrum anti-seizure medication? The answer is no. But look at the comorbid condition here. We have a woman with end-stage kidney disease. So what are we going to choose? So probably we want to choose a medication that kind of doesn't rely on the kidneys for excretion. And she's on end-stage kidney disease and on dialysis. And, you know, a medication that does not get dialyzed easily, and, you know, you run into the problem when around dialysis that the patient may have seizures. So what are the choices? One might think of valproate. I do have a problem with valproate. Its metabolism in the liver, it may not get affected by the end-stage kidney disease, or because it's highly protein bound, it does not get affected by the dialysis a lot. But the problem we face here is this patient age. Old people are like around this age, starting them on valproate, they may have cognitive problems, sleepiness. So although the way that valproate works might sound kind of attractive to use it, but it would not be my first choice. Now, having said that, although levetiracetam kind of get excreted, renal excreted, and it does not have much to do with the liver, but adjusting the dose for end-stage kidney disease might work, and given supplemental doses like mid-dialysis or close to the end of dialysis may fix this issue with this, you know, that it gets dialyzed, or the accumulation problem. So given small doses like 250 per day or 500. Also, berivracetam, interesting drug. To be honest, it gets metabolized in the liver into ineffective kind of metabolite. In people with end-stage kidney disease, there is 10-fold kind of accumulation of these inactive metabolite, but they do not cause any safety issues. So with berivracetam, in fact, you don't need to change the dosing, and you may use it effectively in these patient population. So these two kind of are maybe good choices. A third choice, phenytoin, I think is a good drug here. Maybe better tolerated than valproate, better tolerated than valproate. So let me move on to the next.
Get these kids in before school starts. Get things started before school starts. That's the best thing. Blue.
So for the sake of time.
Green. Yellow.
This is an absence seizure. I won't kind of play the whole video. The study shows that valproate is a very effective treatment if they have GTCs. If they don't have GTCs, ethosuximide is a very effective treatment. This is a self-limiting kind of epilepsy syndrome. Look at this patient I moving to the right.
Did you make a good deal? Well, we're about to find out. Had you said no deal, your next case choice would have been...
Again, for the sake of the time, this patient loses her awareness, and clearly you could see her eyes looking to the right. She has focal seizures, and she's young, she's planning pregnancy. So if you remember the previous principles that we were saying, the best two medications, safe medication are lamotrigine and levetiracetam. So if the seizure frequency is not high, I think it is safe to start with lamotrigine. However, if the seizure frequency is high, you could use a bridge. You could use like lamotrigine and use a bridge, be it like you could use the benzos, the fact that she has untreated anxiety, kind of calm her anxiety, Or you can even bite the bullet and use levetiracetam, but be prepared that this patient may get worse in terms of her anxiety. Let's move on to the next case. So you have seen the myoclonic jerks, and then he goes on into tonic-clonic seizures. Let's suppose that this is a juvenile myoclonic epilepsy. What would be the best treatment here? The studies have shown that valproate is a very effective treatment for these patients. Another, levetiracetam is another one. I believe racetam will work, but it has not been extensively studied. The benzos, clonazepam is a very effective treatment here. And again, for the myoclonus in resistant cases, we might elect to choose zanosamide. Zanosamide is also a good one. When we talk about myoclonus, especially in progressive myoclonic epilepsy, perampanel. The problem with perampanel is the psychiatric side effect is really high. So these would be my choices for this particular syndrome or myoclonia. I believe this might be the last case I have.
Can you make a fist with your right hand? Make a fist with your right hand. Head turning to the left. So, this way. Can you get 2 milligrams of atropine?
So again, for the sake of time, the point here, this patient has focal epilepsy, but she has a major problem in her liver. So the medication that one would want to use that doesn't have extensive liver metabolism, and levetiracetam is a good choice here. A couple of medications, they have absolutely nothing to do with the liver. They're purely excreted in the kidney. One is pregabalin and the other is gabapentin. The problem with those two medications, when compared to Lamictal in previous study, they were slightly less effective, but they do work. They do work sometimes. In fact, I do have patients that on these medication, and especially if they have comorbid condition as pain, they do work. So levetiracetam, pregabalin, and gabapentin. But keep in mind, they might be less effective compared to other anti-seizure medications. So a few more slides. If you have combination treatment, give a good dose and then add medication with different mechanism of actions. For example, don't use lacosamide with, carbamazepine and phenytoin. All of them work on the sodium channels. Like you just use a medication with a different mechanism of action. If you start a new agent, just titrate that slowly and carefully. Now, try different dual therapies. There is an evidence like combining those two treatments, valproate and lamotrigine, they have a synergistic effect and they are a very powerful combination. But you need to have good experience because to kind of use those two combinations, especially like starting lamotrigine, if someone is already on valproate, might be dangerous and lead to Stevens-Johnson syndrome. Okay, when to stop? I have a couple more slides and then we'll summarize and wrap up. Keep these points in mind. If you want to stop anti-seizure medication, stopping the anti-seizure medication increases the risk close to 3 times compared for continuing treatment. So it's not without risk. And most of the studies, if not all, it was mostly related to focal seizure, not generalized epilepsy. And so most of the generalized idiopathic epilepsies, they don't remit, especially juvenile myoclonic epilepsies, I would not stop the treatment for these patients. Even like I have some patients that are well controlled for 7 years and small doses of medications, but we know that the relapse rate in these patients is like 90%. So I would not do it. Then late withdrawal versus early withdrawal. And the time period that define late and or early is 2 years, like 2 years early, 4 years late. So in one particular study, the late withdrawal, like if they remain seizure-free for longer, like close to 4 years, then the risk of relapse at that particular study was 34% in comparison to the 46% that was done around 2 years. If you have an abnormal EEG, your relative risk of having a seizure is 1.5 times greater. And then the age of onset, if it was, before the 2 years old or after 10 years old. So the ones with the before 2 years old, they have these genetic and resistant epilepsy. It's less likely, that they will have remission from epilepsy and seizure. And, this in between age group, these are mostly related to the self-limiting, epilepsies, the like of absence seizures. If you have history of status epilepticus, intellectual disability, and very frequent seizure, it is more riskier. So if you want to stop, if this is a self-limiting epilepsy like absence, if they have single type of seizures, seizure-free for 2 years, normal EEG, no brain structural abnormalities, and normal neurological exam. So to summarize, this is my last slide. We were trying to choose which anti-seizure medication to choose from. We kept so many points in mind, deciding whether we have a focal epilepsy, generalized epilepsy. We kept in mind the side effect profile of the medication, the mechanism of actions, and if we wanted to combine treatment together. And then I gave example 6 cases, like how did we apply these principles, and then when to stop the anti-seizure medication. Thank you very much. And the videos, I got it from this atlas. Thanks.